Antenatal assessment of Rh-HDN. The objective of the antenatal assessment is to identify women with a high risk of having their babies affected with HDN so that they can be investigated during pregnancy to estimate the degree of involvement for proper management. Investigations should be started approximately the 12th week of pregnancy or the first obstetric visits. 1. Detailed obstetric history. 2. History of blood transfusion. 3. Grouping. 4. Antibody screening. 5. If antibodies are detected, identify the antibody. 6. Father's probable Rh genotype. 7. Typing of the fetus. 8. Antibody-dependent cell-mediated cytotoxicity test. 9. Amniocentesis. 10. Percutaneous umbilical blood sampling. 1. Detailed obstetric history. Women with bad obstetric history or evidence of Rh immunization should be closely followed up. 2. History of blood transfusion. Rh-positive blood transfusion may immunize an Rh-negative woman. 3. Grouping. Abo and Rh grouping including weak D-typing. 4. Antibody screening. The sera of both Rhd-positive and Rhd-negative women should be screened for red cell antibodies on the first visit since some IgG antibodies, Kell, Duffy, Kit, SS, that can cause HDN may be found in Rhd-positive women. Screening for IgG antibodies should be done using zero-group screening cells, 2, 3 or 4 cell panels, by indirect antiglobulin test. 5. If antibodies are detected at any stage, then the following must be done. A. Identify the antibodies with 8, 10, 16 or 20 cell panels. B. Carry out Rh phenotype to confirm the implicated antibody. C. The antibody titer should be established in the first trimester to serve as a baseline. Repeat titer every month. Severity of the disease is generally, though not always, correlated with the titer of the antibody. A titer of L, 32 or above, and a rising titer at repeated testing is significant and is an indication for amniocentesis. Follow-up testing is recommended for any titer greater than 8. The critical titer for anti-K may be lower than anti-D, typically a value of 8. 6. Father's probable Rh genotype. The father's red cells are tested with anti-D, C, A, C and E to determine his Rh phenotype. From these data, the probable genotype can be estimated. Whether the father is homozygous for D cannot be determined with certainty unless he has an Rhd negative living child. However, for C and E antigens, the true genotype can be determined. If the father is heterozygous, there is a 50% chance of the child being unaffected with Rh-HDN. The true Rh genotype of the father can now be determined with the help of molecular blood grouping. 7. Typing of the fetus. It is now possible to do the D-typing of the fetus by using the polymerase chain reaction to amplify DNA obtained from amniotic fluid and chorionic villus sampling. Fetal typing is also available for JKE, JKB, K1, K2, CC, and EE antigens. 8. Antibody-dependent cell-mediated cytotoxicity test. The result of ADCC correlates well with the severity of HDN. High ADCC indicates serious HDN, while if the result remains low until the end of pregnancy, the infant is mildly affected or is unaffected. 9. Amniocentesis. Amniocentesis is usually done between the 28th to 32nd weeks of pregnancy. It can also be done earlier. Amniotic fluid is almost colorless, but in case of an infant with a severe hemolytic process, it is bright yellow due to bilirubin. Amniotic bilirubin concentration can be estimated by spectrophotometric examination, and it is extremely valuable in predicting the degree of the hemolytic process in pregnancy and the severity of HDN. The main indications of amniocentesis are the titer of maternal IgG antibodies of 132 or above, or a rising titer on repeated testing by about 28 weeks of gestation. Previous obstetric history of stillbirth, hydrops, fetalis or neonatal death in Rhd negative mothers. 10. Percutaneous umbilical blood sampling. It is a test of historical significance done in the early 1980s. With the use of sophisticated ultrasound equipment, a needle was inserted into an umbilical blood vessel, preferably the vein at its insertion into the placenta, and a fetal blood sample was obtained. Percutaneous umbilical blood sampling allowed direct measurement of hematologic and biochemical variables and accurate assessment of the severity of fetal hemolytic disease. Due to a high fetal mortality rate of 1.22% and a high risk of FMH, its use has been recommended only under certain circumstances, such as when serial amniotic fluid determinations indicate severe HDN or when hydrops is present.